medicine and planning for studies and planning for data analysis. And it's been designed over 20 or so classes. So I would like to start from the basics. So the first three classes uh, that we had planned were how do you look at evidence, how do you assess evidence, and how do you read a paper. And there are different types of evidence that are available, right from the highest quality meta-analysis, systematic review, to the case control and case study sort of data that is available. So today I'm just going to give you an idea of how to read a paper, and we already sent you two articles that we're going to discuss, looking at how the paper fits into good reading and why it makes a good paper, and how the paper's results were carried forward. That was the third paper which I haven't sent you, which I will discuss with you right now. So let's begin by, this is the first class, so hopefully all this will make sense to you as the course progresses. So I'm just going to share the screen and let's start from that. Is the PowerPoint visible?
Yes, sir. It's visible, sir.
Yeah. So this is the first class on evaluating evidence. It's going to be basic. It's going to build up. It might be a repetition for a lot of you, but there are new interesting facts that you will learn. And hopefully in 2 or 3 classes from now, we will have a better idea of how to look at literature, how to critically evaluate literature, and how to select articles for reading. So this is the first class, and the most important thing, a lot of you read papers for many reasons. For some, it could be reading a paper to make a journal club presentation, reading a paper because someone told you that it's an important piece of evidence, or reading a paper because you want to update your knowledge. But the most important thing before setting out to downloading an article or searching for an article is to convert what information that you need into a question. Unless you ask a standard question, you will not be able to search the literature and you will not be able to evaluate the evidence. This is the single most important point when it comes to evidence-based medicine, is to convert whatever information that you need into a question that can be answered by literature. Now, literature can be vast, it can be a randomized trial, it can be a systematic review, it can be many things. But the first and foremost important thing that you should do is to convert your thoughts into a question. It can be a simple thing. For example, does adjuvant chemotherapy along with radiotherapy in the post-operative setting improve overall survival for high-risk head and neck carcinoma? Or it could be that a patient who has got long-standing mesoethmoidal polyposis, does he benefit from a combination of a steroid spray and an antihistamine? So your question needs to be direct, needs to be focused, needs to be based on a clinical problem that you encounter in practice every day, and needs to be a question that will change your practice dogma and your practice methodology. And it should also be a question that leads to further questions. By evaluating a paper, you always look at whether you can come up with further questions that have been not answered by the paper, so that you can pick up on what has not been done and you can proceed with that. Once you formulate the question, then you start tracking down with the greatest efficiency what papers can answer these questions. And usually these are from published literature. We will discuss of how to search PubMed, Medline, Sightseer, and all the other sites in the next few classes. But the second point in your entire paper reading should be to make a maximal effort to make an effective method to download or to search for articles that will answer your question. And once you get the articles that you need, once you get the literature that you need, you always look at how much you can critically appraise that piece of paper that you have with you. You have to be able to critically appraise the article, the validity of the article, the usefulness of the article, and its clinical implementability. You should be able to implement the results of that paper into your clinical practice. And by using these papers, they can be a standard for you to audit and evaluate your own performance. So these are the reasons why you look at literature, but nothing starts before you formulate a clinical question or a research question. So the question has to be there. You can formulate your thoughts and your other ideas, but the point is you have to be able to make it into a question. Now, this is a very interesting concept. There is a concept called passive reading, and there's a concept called active reading. Now, passive reading is nothing but obedient purposelessness. Basically, what you do is you just start reading the article the way it was written and the way the authors meant it to be read. You start from the beginning to the end, and you're just finishing a job mentally. You read every sentence and every word, and you might find it unengaging and boring and tiresome because you're not looking at the article specifically for your needs. And the problems with passive reading is that it is an inefficient way of reading, and there's little understanding of the rationale and the design of the study. And the impression that you take back is quite shallow. It doesn't really fit into what you need to do. What I would suggest you all to do is to do active reading. Active reading is reading with questions in mind. For example, I mentioned to you, does adding chemotherapy to radiotherapy in the post-operative setting improve outcomes in head and neck cancer patients? So if you have a research or a clinical question in mind, then you can have more reading with more purpose. And you always are more critical with active reading. The evaluation is much more critical. You are much more focused. You are highly selective. Your reading is efficient. It also makes a reading interesting and engaging. You always understand the paper much more in depth, the rationale of the paper in depth, and the experimental design in depth. And you leave after reading the paper with a deep impression. So, unless you have a question in mind and unless you do active reading, you're not going to be able to do justice to that paper, and you're not going to be able to carry on what the the results or the message from the paper into your clinical practice. So everything begins with that clinical or research question. And with that question, you'll be able to critically analyze evidence. Now, there's a very interesting website called Center of Evidence-Based Medicine. It's CEM.org website, and you can download several articles on how to read a paper and what are the levels of evidence, the types of studies, and so on and so forth. They have a lot of PPTs, they have a lot of blogs. It's a very useful website for you to start into evidence-based medicine. And if you look at the evidences that we have, the evidence starts from level 1 to level 5. And the highest evidence that you can have from a prognostic and a diagnostic study point of view is a systematic review with a lot of homogeneity. It shouldn't be a heterogeneous systematic review. And usually level 1A is an SR, a systematic review, and 1B is an individual RCT with narrow confidence interval. The narrow confidence interval is important because it makes the results more reliable and more applicable than a paper which has got a very wide confidence interval, which can make it up to chance. And the lowest evidence that we have is expert opinion, or without any critical appraisal, or something based on physiology or bench research. So that is the lowest evidence that you can have. Usually what we go through are either systematic reviews or randomized controlled trials or cohort studies. So a cohort study usually comes in level 4 evidence, which is not very high, but you cannot expect every a question of yours to be answered by a randomized controlled trial or a systematic review with good homogeneity or a meta-analysis which has got a large sample size. You cannot really expect all of your research questions to be answered like that. So we have to be content with whatever literature that we have, and the commonest papers that you will read in clinical practice, at least in head and neck point of view, would be cohort studies or case series studies. Now, all studies have similar components. Okay, so the components are usually with the acronym PICO. PICO is the study population who is being studied, the outcomes, and the interventions or exposures applied to different study groups. So usually it's a study population with an intervention, with comparisons, and with outcomes. And this is how usually all studies are represented. So if you look at all studies, the descriptive studies only have the population outcome because there is no intervention in a descriptive study. So you can have a survey, which is a cross-sectional study, or you can have a qualitative study. If you're looking at analytical studies, either they can be experimental or they can be observational with analysis. An experimental study is a randomized trial or a randomized crossover trial. So that is how the experimental studies are being done. If it's an observational study with analysis, it can be a cohort study, it can be a cross-sectional study, it can be a case control study. So again, you have to match this with the levels of evidence that you have. But usually the PICO question has to be answered in all studies. That is the patient population, the intervention, the comparison, and then the outcomes. So you have to ask three questions. What was the aim of the study? So was it simply to describe a population and being descriptive? That is a PO study. If you want to quantify the relationship between factors and analyze it, it has to be a PICO study. If it's analytical, was it a randomly allocated intervention? Yes, it is an RCT. No, it's an observational study. And when were the outcomes determined? So you have to see whether the outcomes were determined after the time of the exposure or the intervention, that is a prospective study, at the same time as the exposure or intervention, which is a cross-sectional study, or before the exposure was determined, which is a case control study. Now, the basic problem with studies that we encounter is the problem of bias. A randomized control trial usually tries to negate the problems of bias, but still you have bias issues. You have something called selection bias, where there is a difference between the groups that are being analyzed. It can be due to either improper randomization or just how the groups are being segregated. It can be a performance bias. It's a difference in the care provided to the different groups. It can be an exclusion bias, where there are people who are withdrawing from the trial and based on their differences. And it can be a detection bias, where there is a difference in the outcome analysis. So if you look at the main sources of bias in patient series, what we normally see is a case series. The case series usually have a selection bias. Just give me a second, please. Hold on a second, please. Sorry for the interruption. So if you look at the main sources of bias in patient series, in a normal case series that we usually read in a journal club or we review for reading or upgrading knowledge, there's a lot of bias, especially with the investigator, with the study subjects, the exposure, and the outcomes. And there are two important aspects that you have to remember. One is confounding factors and one is a covariate. The confounding factors are factors that have an effect on other variables that are in question. And covariates are the characteristics of the subjects in question, but not the intervention or not the therapy that has been given to the patient. So there are a lot of ways to avoid confounding and to take into account the covariates. And you should be aware of the fact that the different types of studies have different problems with both confounding factors and with covariates. Now, if you look at a study and if you look at a retrospective case series, there is always something called covariate imbalance. So covariate imbalance is nothing but the personal characteristics of the study population in question. And it need not be evenly matched. There can be differences between the two groups, and this does not have to do with the exposure, or the treatment offered. It's just the baseline patient characteristics. And there are many ways of adjusting covariates between the two groups or taking care of covariate imbalance. And it depends upon the nature of the covariate and the outcome variable. So usually what is done is in the form of statistics. We do log regressions or Cox regressions, depending on whether the outcome is binary or categorical or it's a time to event data. So we have to take care of covariates. And when you read a paper, you will understand that these studies have these statistical tests have been done to adjust for the covariate imbalance between the two groups. So how do you choose the right paper to read? Well, there are several aspects of choosing the right paper. First, you have to make sure it's an original study, or it is a study with a larger sample size compared to a previous study published of the same matter. So it has to be a step up from what is published in literature, or it has to be an original study. Was it well designed? A well designed study, in a case of a retrospective study or randomized controlled trial, will have two arms which are evenly matched with their covariates, which have been followed up for the same amount of time period, where the interventions were uniform and all other confounding factors have been removed. You have to look at who are the subjects included in the study. For example, if it's an oral carcinoma patient, you should have oral carcinoma patients included in both groups of the study, and that is where the inclusion criteria comes into play. And was there sufficient follow-up time? A lot of these papers will have a follow-up time of a year or 18 months, which is not sufficient to measure oncology outcomes, where you expect a minimum 2-year or a 5-year follow-up for these patients to better report the results of your intervention or the prognostic features. So there should be a sufficient follow-up time. Was the risk of bias eliminated? I mentioned to you that bias, there are several types of bias. Usually in a randomized controlled trial, the bias is eliminated by randomization. In a non-randomized trial, it's done by statistical methods. So the bias has to be eliminated, the covariates have to be adjusted, and the confounding factors have to be taken into account. And are the results credible? The results should sound meaningful to you, and they should sound practically implementable to you in your clinical day-to-day practice. So these are the important things that you look for before choosing the right paper. So what are the 6 questions you ask before reading the paper? So the 6 questions are: what do the authors want to know, or what do the authors aim to prove? What was their motivation? What did they do? What were their approach and methods? Why was it done that way in context with the field? And what do the results show? How do the authors interpret the results? And what is the thing that you do further beyond reading a paper? What should be done next? And this can be something that you develop on your own after reading a paper, or you read the paper where the paper's discussion mentions the drawbacks or limitations, or you have read the materials and methods and found a statistical flaw in their analysis and you want to do something more. So at the end, every paper should direct you to a future question. There are 2 endpoints to any paper. The first endpoint is implementing it into your practice, or 3 endpoints: implementing one into your practice. Second is to audit your own performance. You might follow the same methodology as the trial is reported. That might be a clinical practice already. You can do an audit of your own performance and see whether it matches with the results of the published paper. And the third is that you get new questions directed for you to start analyzing or start writing up a new research article yourself. And the most important way you do that is either by going through the limitations of the study, or by what is mentioned in the discussion of that paper, or your understanding of the research methodology. One of the important things for a paper to be good is the sample size. Now, for a retrospective study, unfortunately, there is no way to calculate a sample size like how you do it in a randomized controlled trial. So it should be a large enough sample size for them to draw statistically significant endpoints. That is what is important. And the second point about a sample size or the sample in question is that the study population should be generalizable. It should fit your patient population or the patient population that comes to your practice or to your institute. and how were the subjects identified and included. There should be a specific inclusion criteria, there should be a specific exclusion criteria. Only then you would understand what intervention and what prognostic feature affects that particular patient. So unless these three things are defined in the sample size, the sample size description is inadequate. Now, for overall reading, there's a very interesting concept described by Keshav from Canada. So he says that we should read an article in three passes. There is a first pass, there is a second pass, there is a third pass. This paper was written with computational biology in mind, so I have modified it slightly for us to fit into research for our own head, neck, and ENT purposes. So the first pass is when you read the title, abstract, and introduction. He has mentioned you read only the section and subsection headings afterwards, but I would suggest that you read the methods and results, you read the conclusions, and you glance over the references. So this is a very short process. It takes you about 15 minutes to do a first pass reading. And you should be able to answer the 5 C's after reading the article in the first pass. So one should be the what category this article fits in, what was the context the study was done, how correct the study was done, what is it contributing to your understanding or to literature, and how clear are the endpoints or the conclusions. The second pass is when you go back to the paper and you evaluate figures, graphs, and the illustrations. Many a time, if you look at the figures and graphs and illustrations, the X and Y axis may not be marked correctly. There might not be a legend behind the graphs or a legend behind the illustrations. All of this points to a poorly written article. So you know, and you can judge the quality of the article by the illustrations and by the graphs and figures. In the second pass, the first pass, you just glance through the references. In the second pass, you make a note of the unread references and you go back and read them, because that's the reason why a reference is put in an article. You have to be able to go back and look at the references and read the references that you're unfamiliar with to get a broader understanding of what the paper was meant to be and why the authors did that study. And if there is a new statistical test or term, you cross-reference the term and then you continue reading. And the total time that you spend with this is 1 hour. So you have 15 minutes for the first pass and then you have an hour for the second pass reading. And this gives you an overall idea of the paper, and this should suffice for many of you. But the third pass is the key to the best understanding of a paper. What you do in the third pass is you virtually re-implement that paper. You write up your own research question. You write up your own, this is all virtually done. You just imagine your own research question in line with the paper. You imagine your patient population, the inclusion criteria, the exclusion criteria. You decide what statistical tests that you would do for that patient group. You would look at what endpoints you want to study for that patient group, and you would look at what references and discussion you want to do. So you're basically closing the paper and virtually recreating the paper and seeing if they are both comparable. So when you compare your understanding of the paper virtually with what has been published, you can understand not only the paper's innovations, but also its hidden problems and its hidden assumptions. And you should be able to identify and challenge every assumption in every statement. That's what happens when you virtually recreate the paper in your own terms and you're able to write that on a piece of paper and then decide whether the paper was written well or not. So after you critically evaluate every line of the statement, you should think of what is the best way you would represent that idea, and what extra tests you would do, or what extra statistical analysis that you would do to get the article complete and the meaning complete. So the comparison between the actual paper and the virtual gives you a lot of idea and will add to your understanding of the paper in great detail. So that is what I do. Every paper I read, once you've read the paper, I close the paper up. I just keep the introduction, the abstract with me. And then I would decide, okay, they're comparing two groups. These are the endpoints that I would like to study. This is the statistical test that I would like to employ. and these are the endpoints that I would like to study. Then I open the paper up again and see if they have done the same. And then I might jot down my own ideas. Why did they not include local regional control? What was their problem? Why did they not look at any specific subset rather than generalizing the whole of head and neck? Did they have a problem with sample size? Did they have a problem with the power of the study? So you write down whatever you thought was incomplete in that paper, and that gives you an idea to read further papers or to come up with your own research question and your own research methodologies. So virtually doing the paper up by yourself gives you more and more ideas than you can imagine, and this process takes hours to days. It doesn't happen overnight or doesn't happen an hour after you read the paper. And these are usually reserved for randomized trials or retrospective multicentric studies or retrospective articles which have a lot of patients. So it takes a lot of time and it takes a lot of effort, but it will definitely help you in getting your bearings for your future publications. So with this very basic introduction, we had planned to discuss three papers. And the three papers which we're going to discuss were, I had already sent them across to you. The two I had sent across to you, but the third one I hadn't sent across. So this is just for you to understand how a paper has been written. Are you able to see the article on the screen?
Sir, no, sir, not seen, sir.
I'll just put the article on the screen. Yeah. Is it visible now?
No, sir. Yeah. Now it's visible, sir.
Okay. So this is a very basic question that has plagued head and neck surgeons for a long time. And this is an article that was published in the 2000s, so it's a very old article. But this article has a lot of meaning for understanding and for reading, so that is why I'm sharing these articles with you. So the simple question was, my research question when I read this article was, does adding chemotherapy to post-op radiotherapy help locally advanced head and neck cancers? That was my research question. Very broad research question, but very specific point that I wanted to know is whether chemotherapy is going to help patients who are receiving adjuvant radiotherapy for high-risk resected head and neck cancer. So there were two trials published in this regard. One was by Bernier, other was by Cooper, and one was an EORTC study. The other was an RTOG study. There were two clinical trials. They were published in the NEJM, which has got a high impact factor, and it's a well-reputed journal. So when you start reading the article, you have to look at the abstract first, because the abstract is what is going to make you want to read or not read an article. The abstract should be able to answer the 5 C's question that Keshav had mentioned in his article. And the abstract should be concise, and it should be able to give you most of the conclusions that are required in the understanding of the study. So hold on for a second, excuse me. So you see the background of the study. They have a very select patient population. That is very important. If you're looking at whether post-operative antibiotics help in a patient who's got post-mastectomy surgery, or whether the drains are relevant in a patient who's got post-thyroidectomy, can you do drainless thyroidectomy? So you should have a very specific patient population in any study that you see. Can be a retrospective study, can be a prospective trial, can be a meta-analysis, but the patient population should be very specific. So in this study, they have a very specific patient population, that is stage 3, stage 4 head and neck cancer. And they're looking at a specific subsite in those patients, that is those who have been operated and those who are receiving adjuvant treatment. So this ticks the box for a select patient population and for a selected treatment. Now, you always have to remember that whatever comparison that you're doing from an intervention point of view, one should be the gold standard and one should be the experimental treatment. You cannot have two experimental treatments in a trial or in a study, because it makes no sense. You always have to compare with the gold standard. So here the gold standard was radiotherapy prior to the trials being published, and they're trying to compare chemoradiotherapy versus radiotherapy for a locally advanced head and neck cancer, that is stage 3 and stage 4 cancer. So the patients were all operated. They had the adequate sample size calculated by the statistician, and they had randomized the group so to avoid bias and to make the results more meaningful. And they have given the standard treatment of radiation, that is 66 gray. Treatment has been given over 6.5 weeks, and they have given to the experimental arm the same radiation with 100 milligram per meter square of cisplatin, which is the gold standard drug for head and neck adjuvant treatment or even for concomitant organ preservation, on days 1, 22, and 43. That is week 1, week 3, and week 5. So, am I audible?
Yes, sir. Audible,
Bhargav,
sir. Yes, sir.
sorry,
Audible, sir.
I'm streaming through my phone, so I'm not sure if the internet connection is good. So we cleared two facts from the top of the list. We have a targeted patient population. We have a targeted patient population which has been operated, which is receiving adjuvant treatment. Prior to the study, no one has talked about giving chemoradiation to the patient in the adjuvant setting, so they have an experimental arm. The gold standard radiotherapy arm is also included for comparison. They have randomized the patients. The treatments that were offered are gold standard. That is, in the gold standard arm, that is the standard treatment arm, the radiation has been given in the right dose, right fractionation with linear accelerators. And the chemotherapy arm has also been standardized by previous retrospective studies. So everything so far looks as if the patients have been receiving the right standard treatment and treated. Now, if you look at the results, they had a median follow-up of 60 months, which is a sufficiently long time for them to look at the outcomes. And then after you look at the follow-up time, you have to look at the what endpoints did this study measure. So in this study, the endpoints that were measured were the progression-free survival and the overall survival. That were their primary endpoints that they had studied in this paper. The other endpoints that they had studied were the estimated incidence of local and regional relapses. And then they looked at the side effects of patients who are receiving chemoradiotherapy. So keep in mind, they're looking at progression-free survival and they're looking at overall survival. They're not looking at local regional control. They're not looking at local regional recurrence rates, none of that. They're looking at progression-free survival and overall survival. And from the abstract, you can make out that patients who had the combined therapy had better progression-free survival compared to patients who had the individual therapy. And also the overall survival was better in the combined therapy group than the individual group. And in the secondary endpoints, the local and regional relapses were lower in the combined group because all the p-values are significant. And uh, the adverse reactions were higher in the combined group compared to the radiotherapy group. So from the abstract, you understand the patient group in study, the intervention that was given for the patient, the follow-up duration of the patient, what endpoints were studied, what endpoints were statistically significant and what were not significant, what were the secondary endpoints that they have studied, especially if a new therapy is being offered, you have to look at the side effects and the quality of life, and the conclusions of the abstract. So this makes it a very good abstract for us to read. So when you come to the introduction of a study, the introduction of a study is extremely important because the introduction is what gives you the background for why the study was done. Every paper should have a good introduction. The introduction should not be speculative. That means the author should not speculate in the introduction by quoting experience or by quoting unpublished literature on why the study was being done. So if you look at this paper, they have categorically mentioned which patients fail in cases of head and neck cancer. For example, the risk of failure is high with poor surgical margins, with extranodal spread and multiply involved nodes, and they've quoted references for that. Then they've also quoted the use of radiotherapy as an adjuvant treatment and also the efficacy of chemotherapy as an adjuvant treatment from several retrospective studies. And hence they have told that they wanted to do a randomized control trial. So the introduction is not expansive. Introduction clearly states who are the locally advanced high risk patients. The introduction also clearly states that the gold standard has been radiation, but there has been evidence to support chemotherapy in a non-trial setting as a retrospective study. and hence they had done the trial to compare adjuvant chemoradiotherapy with radiotherapy alone. So this is very important. The introduction should not be speculative. The introduction should have a background of the problem, the background of evidence that has been available so far, retrospective analysis was done. Second thing is the materials and methods should categorically mention who are the patients eligible for the study and who are the patients that were eliminated from the study. So if you look at this paper, you're looking at locally advanced head and neck cancer. So obviously the patients who are included are patients with stage 3 and stage 4 disease. And the patients who you don't want to include are those patients who cannot tolerate surgery or who cannot tolerate adjuvant chemoradiotherapy or who cannot tolerate chemotherapy because of poor blood counts, that is white blood counts, or poor creatinine clearance or poor platelet counts. So the inclusion criteria is advanced patients of T3, T4, patients who had nodal stage 2 or 3, patients who had unfavorable pathological findings like extranodal spread, positive margins, peritoneal invasion, or vascular embolism. All of these patients were included in the study, as well as patients who had oral cancers or oropharyngeal cancers who were stage 3 and stage 4 at levels, who had lymph nodes at level 4 and level 5. So this was their inclusion criteria, which has been very clearly described. The exclusion criteria, as I mentioned, as those who cannot tolerate any of this, that is, who've got a poor performance status, patients who've got a poor creatinine clearance, patients who've got a poor white blood count, patients who've got a poor platelet count, and patients who've got bad liver function. So these are patients who obviously cannot tolerate chemotherapy, and hence these patients were excluded from the study. Now, this was a multicentric study across several institutes, and they had standardized what their resection margins were. They had uniformly patients receiving 54 grade 27 fractions for the primary site and regionals, which were the regional lymphatics. And the high risk regions got a 12 gray boost, so it was 66 gray and 33 fraction. And they had limited the spinal cord dose to 45 gray. And cisplatin, as I mentioned to you, was 100 milligram of cisplatin per meter square on day 1, 22, and 43. And the patients were also followed up as per the standard norm. That is, they were followed up for 2 months for the first 6 months, 4 months for the next 24 months, 6 months for the next 2 years, and annually after that. And if you look at any trial, usually the trials are designed to detect an absolute increase in their outcomes by 15%. And the statistical power is usually at 80%. Some of these trials have an interim analysis done during the recruitment period. I mean, at the end of the recruitment period, and the results are being published. But most trials will publish the final results after the full follow-up data is available for the trial investigators. So in this paper, they had done the study from 1994 to 2000. They had 334 patients with 23 institutions. Their baseline characteristics were quite similar. That is, male, female habits, the type of tumor, the stage, the site of tumor. Most of them were in the comparable group. So that is why you have to look at the table with characteristics of patients and tumors. And you can see here that most of them were comparable. Most studies would include the p-value also to show if any of the findings were different between the groups, but this paper has not shown that. So most of the groups are comparable. The only problem in this trial was that their chemotherapy compliance decreased with the courses delivered. That is, majority of the patients got the first and second cycles, but the third cycles had problems with delay, and only a smaller number of patients got the third cycle of chemotherapy. And as I mentioned to you before in the abstract, the severity of grade 3 and grade 4 adverse effects were higher in the combined group than it was there in the radiation only group. So when you read the abstract, you know that the abstract mentioned two endpoints. Progression-free survival. They found that patients who had the combined modality treatment had a better progression-free survival than patients who had single modality adjuvant treatment. So after a median follow-up of 60 months, there were 194 failures totally, 103 in the radiotherapy group and 91 in the combined group, which was statistically significant by the log rank test. And if you look at the overall survival of the patient, unfortunately, because it's a locally advanced head and neck cancer, 50% of the patients expired by the end of the study. But there was a difference between the radiotherapy group over the radiotherapy group. And the estimated 5-year incidence of relapses was less in the combined group and more in the single modality radiation group. And this was done by Gray's test. Gray's test is slightly different from a log rank test, whereas in Gray's test, you don't take into account censoring. So we will discuss the different types of tests in the subsequent classes. So by Gray's test and not a log rank test, they found out that the regional relapses were more in patients who had radiotherapy than the patients who had chemotherapy. Patients who had radiotherapy than the patients who had combined modality chemoradiation. And they also looked at the incidence of metastasis, which was not part of their abstract, and they found that the metastasis between the two groups were not significantly different. And the incidence of complications, as I had mentioned to you, it was not significant in the long term. The early complications like mucositis and so on and so forth were more common in the cases of combined modality radiation and chemotherapy, but the incidence of late side effects were not much different between the two groups. So once you've read the materials and methods and the results, and you have an idea of what the endpoints measured and what were the significant endpoints, then you go to the discussion. So the discussion again should not be speculative. It should be based on evidence. And for every point that the paper states, for every result the paper states, there should be a comparison from their results with published literature. So here you look that they have talked about how studies have been done where they have tried to add sequential chemoradiotherapy, where they have tried to add radiotherapy for decreasing the nodal and distant failures, but they couldn't find an improvement in survival. Whereas this paper has found an improvement in survival by adding chemoradiotherapy. And they've also talked about how cisplatin has been administered, why the dosage of cisplatin used in the study was decided, and what the papers have mentioned about the previous studies that have been published with this dosage. And then they've also looked at their results, and they have compared their results to radiotherapy alone based on previous trials also. So there's nothing speculative in the whole results section. In the section, they are comparing their own results with results that have been published so far. And they've also looked at the drawbacks of their paper. So the drawbacks of the paper said that combined therapy did not reduce the possibility of a distant relapse. So that was one of the points that they couldn't find positive in their study, and they wanted to highlight the point that discusses isn't being reduced by the combined treatment. Now, their results, this is a very interesting statement that they mentioned. These two trials, that is Bernier and Cooper, have been published in the same edition of the NEJ. They have mentioned that the magnitude of the combined chemoradiotherapy has demonstrated comparable results. And in that trial, we will discuss the trial next. Their trial did not subgroup analysis. So they weren't able to show which subsite particularly benefited from this adjuvant treatment. So they have trying to mention that their selection of adverse pathological features might not be the general assumption of what adverse pathology need to be, and hence you have to do more studies into identifying which pathological feature benefit most by adding chemotherapy. And their conclusion was, if you do surgery with curative intent, giving adjuvant high dose cisplatin and radiotherapy advanced squamous factors. And their study, they found that the progression-free survival did not have any subgroup analysis to say which site benefited the most, because if you look at their tumor site, they had tumor sites from all sites in the head and neck. So the majority was oral cavity and oropharynx, then hypopharynx, larynx, and then unknown primaries in very small subset of patients. So they weren't able to decide which subsite benefits the most, and they weren't able to do a subset analysis on which adverse pathological feature, for example, which adverse pathological feature amongst this whole group of adverse pathological feature had significant benefit. They just bunched them into a complete group as a high risk patient, and then they gave the results and conclusions. So from this paper, we can understand that patients who have stage 3, stage 4 disease, patients who have head and neck primaries, patients who have advanced tumor stage, who have extranodal spread, posterior section margins, perineal invasion or vascular embolism, all benefited by the addition of chemotherapy to radiotherapy, and this affected the progression-free survival and the overall survival, but not the metastatic control. Now, a different twist on the same question was answered by Cooper. They also looked at the same targeted population, that is high risk squamous cell carcinoma. We will see what their high risk definition was. And they also tested whether the post-operative administration of cisplatin along with radiotherapy helped to improve local and regional control only. They didn't look at overall survival in their primary endpoint. They looked at only local and regional control. Again, this was a multicentric study with 400 and can you see the second paper, Bhargav? Hello?
Yes, sir. Yes, sir.
You see the Cooper's paper? It says sharing is paused. Can you see the second paper?
No, sir.
You're not able to see this.
So stop it and restart it, sir.
Yeah,
Stop
I'll
the
just
sharing
stop
and restart it.
Yeah, I think it should be visible now.
Yep. Just now it has come. Yes, sir.
Yeah. So, so the second article, which is published in the same issue of NEJM, was a similar question asked that whether addition of adjuvant chemotherapy to radiotherapy improve outcomes. But the outcome measure that was studied in Cooper's paper were different from the previous paper that I had mentioned to you. And their inclusion criteria for a high-risk patient also differed. So this is further adding to your knowledge of which patients will benefit from a adjuvant chemoradiotherapy. So this was also a multicentric prospective trial, had a higher patient group, that is 459 patients, and they had 231 patients who were receiving radiotherapy against standard fractionation, no change, no hyperfractionated, hypofractionation, no different accelerated fractionation. This is a standard radiation regimen given to patients, and 228 patients received identical radiotherapy with cisplatin at these doses, 100 milligram per meter square on day 122 and 43. So there is a standard golden arm for treatment, standard arm. There is an experimental arm. The radiation doses are standard. Chemotherapy dose is what has been described in literature before. There's a very specific group of patients who are being analyzed in the study. And the the question that you're willing to answer or you're looking for an answer is also very specific. Now, if you look at the results, the follow-up period is a good time, that is what, 46 months. And they looked at the rate of local and regional control. So local control is the tumor bed, regional control is a nodal recurrence. And they found that the local and regional control was significantly better in the combined group than in the radiotherapy alone group. And they also found that the 2-year estimated control was better in patients, 2-year estimated local and regional control was better in patients who had combined therapy than patients who had radiotherapy alone. And their disease-free survival was longer in the patients who had combined therapy and radiotherapy. So the previous paper was progression-free survival and overall survival. Here we're talking local regional control and disease-free survival. So this is very important for you to understand if you want to justify concurrent chemoradiation post-op to your tumor board or to your patient. you have to tell them that it's not the progression of the tumor alone, it's the overall survival, it's the local regional control and disease-free survival that you're improving by adding the chemotherapy. But unfortunately, this paper did not find a statistically significant improvement in overall survival. And the incidence of acute grade 3 and grade 4 reactions were higher in the patients who had received combined therapy than the patients, which is understandable that chemotherapy gives you more adverse effects. Now, the difference between the Bernier and Cooper paper is that even though they were answering the same broad question, that is combined modality post-operative chemoradiation for a high-risk group, their inclusion criteria was slightly different. Here, the inclusion criteria were involvement of 2 or more regional lymph nodes, extracapsular spread, and microscopically involved margins of tumor resection. There, you had perineural spread, you had lymphovascular emboli, you had level 4, level 5 lymph nodes, and patients who had oral and oropharyngeal primary. So here, the inclusion criteria is slightly different, but obviously the patients who are included had to be able to tolerate the surgery, the chemotherapy, the radiotherapy. That means they have to have a good creatinine clearance, they have to have a good blood count and hemoglobin, and thereon and therefore. So they had a good exclusion criteria and a good inclusion criteria, and this is different from what Bernier's data had included. And here the primary endpoint was local and regional control, and the secondary endpoints are probably the disease-free survival, overall survival, and adverse effects. And they had randomized their patients. You can look at the division of the patients. Oral cavity is the oropharynx is a higher group than the oral cavity in this study, and all the other factors were quite evenly matched between the two arms. That is the radiation arm versus the radiotherapy versus radiotherapy plus chemotherapy arm. So if you look at the tumor control, they found out that patients with a median follow-up of almost 46 months, they were better loco-regional control in the patients where the combined group of combined therapy, that is, radiotherapy was 30% and 90% recurrences in the combined group, and this was statistically significant. And the 2-year control of local and regional recurrences were also better with the combined therapy, that is at 82% versus 72% for radiotherapy alone. This was for their local control and loco-regional control. And they looked at disease-free survival. The disease-free survival was significantly longer for patients who had combined modality treatment than patients who had just radiotherapy post-op. And the overall survival was not statistically significant, which is unlike the first paper that Bernier had published, where overall survival also had improved. And you can see here, only 60% of the patients, like in the previous paper, completed all 3 planned cycles of chemotherapy. That is a problem that you have to take into account when you are doing chemotherapy for your patients, and that is probably a drawback of this regimen. And patients progressively drop. So 23% of the patients received 2 cycles, 13% received 1 cycle, and 2% received no chemotherapy at all. And adverse features, adverse effects from the treatment were the same as compared to the previous paper that has been published. So if you look at the discussion here again, the discussion here again is not speculative. They have looked at what their study and had reported, and they had compared their data with Bernier's data, because I think they had a chance to review each other's literature before they had published. But then they looked at the difference. They mentioned the differences between the what's constituted a high risk group in Bernier's study and what constituted a high risk group in the Cooper study. They have highlighted that fact. They've also highlighted the fact that they had better disease-free survival and they had better local regional control, but they've also acknowledged that their overall survival was not better compared to the previous paper. And the uh, the thing about this paper is that they've also talked about the morbidity associated with severe adverse effects. That is, 2% of patients who had concurrent chemotherapy died as a result of treatment, then none of the patients who had radiotherapy died. And 27% of the patients had a grade 4 or grade 5 toxicity compared to 7%. And again, they could not find a benefit for distant metastasis improvement with their chemotherapy regimen. So they also concluded by saying that they should, give concurrent chemoradiotherapy, but should not be applied to all patients who need post-op radiation. In particular, they cannot be applied to patients who do not qualify for this trial, meaning that whatever high-risk features that have been mentioned in this trial, unless the patient has that high-risk feature, you should not use them in your clinical practice. So these papers, both these papers as trials, have given you what their merits were, what their demerits were, and they've also told you that they have not done subgroup analysis, sub-site analysis, and they cannot extrapolate this data between the two studies. These two studies have had different inclusion criteria and hence the difference in outcome. Now, you would think that once you publish two papers, which are mentioning that there are two different high risk groups. Bernier's paper has said that patients who have ENE, positive margins, level 4, level 5 lymph nodes, and oral cavity oropharynx primary as high risk group, whereas Cooper has given a different set of patients who are a high risk group. So, how do you decide which, based on these two studies, which is a common pool of patients who will benefit from post-op chemoradiation? That is where going beyond a trial, going beyond a study comes into play. And this was a combined paper that was done where they combined pooled the data from both their studies. So Bernier and Cooper combined their EORTC trial and the RTOG trial together, and then they decided which patients will have the maximum benefit for adjuvant chemoradiation. And this is just an example for you to show that reading one trial is not sufficient. You might have another trial looking at the same research question, but might have a different inclusion criteria, might have a different endpoint, might have a different drawback, and you will always find some paper which has combined these trials or a large population-based analysis retrospective study which has included all the findings of this trial and has given you real-world outcomes. So Bernier and Cooper were very clear in their study where they looked at both their data, and what they found out was when they combined URTC data versus the RTOG data, they found that in the EORTC, as I mentioned, stage 3, stage 4, oral cavity, oropharynx with level 4, level 5, perineural and vascular embolism. In the RTOG, and plus margins and ECE. In RTOG, it was margins plus ECE plus 2 or more positive lymph nodes. When they had done their statistical analysis, they found out that the common denominator was patients who have margins positive and who were ECE positive benefited from chemoradiation. So this goes to show, I'm not going to discuss this paper in depth. We will discuss this in the subsequent classes because I have to discuss this with regards to forest plots and how do you look at hazard ratio and things like that. So we will discuss this in the subsequent classes. But this is just to show you that there has been data extrapolated from two published articles where they've looked at common denominators. So the trials are not the answer for all your evidence. The trial has to be replicated in a real world scenario. So what has happened is after all this data has been published, there's a large retrospective study from I think the SEER database or the NCDB database where they have shown that as a retrospective population based study, they have shown that patients who have positive margins don't need adjuvant chemotherapy. Only those with ECE need adjuvant chemotherapy. So literature is a continuum. You might have a trial, you might have another trial after that, you might have a combined analysis of the trial, you might have a population based paper based on the results of the trials which have been implemented, and you might find different answers. So reading literature is important. What you should do is look at the question that was asked, look at the inclusion criteria, look at the endpoints that have been measured, the sample size, the follow-up duration, what was significant, what was not significant. Look at the discussion and introduction. Both of them should not be speculative. Both of them should have comparison with published literature. Look at the discussion for them to volunteer the drawbacks of the study. You virtually recreate the study in your mind and look at what extra statistical tests and analysis that you would do and formulate your own study based on the drawbacks or subgroup analysis, and then look at the references very in depth because the references are going to give you a lot of background reading, and with these references you will be able to fill the lacunae in your knowledge. How do they come to this study? How do they decide that this study has to be done? What was important for them to do the study? All these things can be made out once you're able to bring in the previous literature and previous studies that have been published in literature so far. So this is just an introduction for you with 3 papers to show how literature has to be read, the continuum and all that. I started with a clinical trial because it is easier to explain why the randomization. We don't have to talk about bias. We don't have to talk about covariates and other things like that, confounding factors and things like that. The next class is going to be a much more critical evaluation of a retrospective study. That is what you commonly read in day-to-day practice, where we are going to talk about univariate analysis, multivariate analysis, what is a qualitative study, what is a quantitative study, and we are going to discuss about the different ways that the results have been demonstrated. So any questions now, I'll be happy to take.
Sir, good evening, sir. As of now, there are no questions. So I request anyone, if you have questions, kindly put it in the chat box or raise your hand so that I'll post to sir. Dr. Suti, all the papers will be shared in our WhatsApp groups. I'll just give you, I'm just sending you the link so that you can add yourself in the Telegram group. If no one is there, I have sent the Telegram group link in the chat box. So all of you please add to it so that next time I'll distribute all the papers and reading materials beforehand. Sir, Dr. Nitya is asking for the next webinar if there is any papers that we can go through.
Yeah, so
Retrospective
the
papers.
next webinar, I'll send 3 papers for the next webinar.
Yes,
One
sir.
is a single institution retrospective study,
Okay.
and the other 2 are multi-institution retrospective. One is a multi-institution retrospective study, and one is a population-based study. And we are going to focus on not what the abstract or what the discussion was, but what the statistical test that they have used. So there's going to be the next 2 classes are going to be on quantitative and analysis in literature.
Sir.
Yeah.
Yes.
So
Sir.
that will be from 2 weeks from now. I'll send you the 3 papers in the next 2 days. And the next discussion is going to be on quantitative and qualitative analysis.
Sure, sir. So as of now, there are no questions. So we will take a leave for today, and we will be updating all our papers in the WhatsApp group as well as in the Telegram group. I request everyone to kindly add yourself in the Telegram group because it's a larger group, and every people will be good discussion can happen there. So
Yeah.
with this words, I thank Deepak sir again for giving us the opportunity to talk, and we will take a
No
leave.
problem. Thank you so much for your attendance. Yeah.
Thank you, sir.
Thank you. Thank you so much.